This is Dr. Douglas Martin. He is the clinical director and an associate professor, right, at the Radiation Oncology Department. Dr. Martin.
Good morning. We got a little few minutes left in the morning. The staff have done a great job organizing this. So I'm a radiation oncologist. Erica did a great job kind of leading into what I'm going to talk about. I'm going to talk more about the radiation part of the treatment for ocular melanoma, choroidal melanoma. Whoops, it's just a little slow. Okay, there it is. And I'm going to go through some of these slides fast because Erica covered a lot of it, but it is an uncommon tumor, but it is the most common tumor in the eye. Roughly about 1,500 new cases of choroidal melanoma in the US a year. If you think about breast cancer or prostate cancer, are somewhere around 200,000 cases in the US a year. And so this is a relatively uncommon tumor. They do tend to grow slowly. Like skin melanoma, they do arising. There is the potential to spread. You've already heard that. And like many cancers historically, as was already said, the primary treatment early on and for many, many years was surgery. You've kind of heard that. Small lesions can be followed because they may not grow into melanomas. As they get larger, they really do need to get treated. Typically, we categorize them from our end of it, from radiation. If they're medium-sized lesions, those are typically the ones we would treat with radiation high plaque brachytherapy. If they're larger, in some cases, we'll treat it with radiation. Otherwise, they might need surgery. Again, you just heard this. Historically, the most common way to treat this was to remove the eye. If there is a more aggressive tumor that's actually invading outside of the eye, then they have to even do what's called an orbital exoneration, which is removing the entire contents of the orbit. I'm not sure I've seen anybody ever resect part of the eye, but there is the laser treatment. Radiation is used in many cancers, and in order to try to preserve vision, there was a lot of work trying to figure out can treatment be done safely to preserve the eye, preserve the vision if possible, and avoid removing the eye. Radiation is an effective treatment for skin melanoma. In many cases, we'll add that after surgery or instead of surgery in localized areas where there's high risk of cancer coming back or cancer that can't be removed completely by surgery. One of the things with special techniques, we can deliver very, very high doses to focal areas with radiation, and that's what's often needed in melanoma. Just a little bit of history of radiation. I won't spend too much time on it because I know you want to get to lunch, but radiation has been an effective tool for treating cancer for over 100 years. Nearly 2 out of 3 patients that have been diagnosed with cancer at some point in the care of their cancer will receive radiation. Sometimes that may be in the curative setting as part of treatment or the only treatment, and other times it may be if the cancer has spread, it helps to relieve symptoms or control cancer in certain parts of the body. This is supposed to be 2015 as a typo, but it doesn't matter. In 2005 or 2015, over 1 million patients a year receive radiation in the US. And there's over 24 million treatment visits across the US to different radiation oncology centers. Radiation is not very old. We didn't know about radiation until about 120 years ago. William Röntgen in 1895 discovered X-rays when he was experimenting with a cathode ray tube and found that when he put his hand between that tube and a screen, a fluorescent screen, he could see the bones in his hand. I think this is actually supposed to be supposedly his wife's hand in her wedding ring, a picture that's kind of seen often. He did that in November and published it shortly thereafter, and that got widespread coverage both in Europe and in the US. Just a year later, now Röntgen discovered X-rays, which is X-rays made from a machine. A year later, Henry Becquerel discovered radioactivity because we have radioactive material, uranium, radium. Most of you have heard those things. They're radioactive materials that occur naturally in nature. And he discovered radioactivity. And a couple years later, Pierre and Marie Curie discovered radium and polonium. Well, this brand new discovery, within months, people started using it for everything. but one of them was cancer. They used it to treat acne, they used it to treat other skin conditions, but they did use it to treat cancer. And probably the first person to use radiation in the US was a physician in Chicago, Emil Grubb, who within about less than a month after the publication got to the US of Röntgen's discovery, used radiation to treat a patient with breast cancer. So you heard from Eric a little bit about the different types of radiation that can sometimes be used for choroidal melanomas. And we're going to talk a little more about that, mostly about the plaque brachytherapy the rest of this talk. But you heard about protons. Helium ions are even less available. There's one place in the US that used to have it. There's a couple in Japan, one in Germany. It's not usually used for treating melanomas of the eye. Protons can be used and is very effective. But like Erica said, there are more proton facilities across the US, but very few proton facilities actually have the capability to treat choroidal melanomas. It needs to be very specific, and Harvard, Boston and Harvard, and then MD Anderson down in Texas are probably two facilities that do have a reasonable program to treat choroidal melanomas. But it's much less common than the plaque brachytherapy. There are a few reports using the gamma knife to treat choroidal melanomas. There was a doctor in Indiana that would stitch the eye in place and they would do gamma knife. Nobody else has picked that up. It's really kind of, since they stopped doing that there, I don't know that anybody's using the gamma knife anymore for that. The most common treatment is the plaque brachytherapy that we're going to talk a little bit more about today. Excuse me. So what is brachytherapy? Brachytherapy, the word brachytherapy comes from the Greek brachios, which means short distance. And what it means is putting radioactive material either into the tumor or up against the tumor, either on the surface of the tumor or into a cavity that is adjacent to the tumor. It's very effective. It's been used. It's been used since the early 1900s. Actually, Marie Curie loaned out her radium that she had concentrated to physicians to use in treating cancer. That was where the first radium came from. Historically, and even now today, most patients that are treated with brachytherapy, it's usually either prostate cancer or gynecologic cancers. There are other applications as well. Certainly choroidal melanoma, using eye plaque brachytherapy is a very, very common, it is by far the most common way to treat choroidal melanomas or eye melanomas. I won't get into a science lecture here, but brachytherapy sources primarily in the US, the radium is the only naturally occurring radioactive material that has been used in treating cancers. We don't use radium anymore. It's got a really long half-life. It's really complicated to take care of, and the majority of the radioactive sources that we use today are radioactive sources that are man-made, and they usually are made either in a nuclear reactor or in a cyclotron, and we won't get into that. So the history of ocular brachytherapy or treating choroidal melanomas is pretty long. 90 years ago, was the first, at least, report that I'm aware of that treated eye tumors with radioactive implant. And in that report, they took radon seeds, which is a daughter of radium, and planted the seeds into the tumor of the eye. The first plaque brachytherapy was using radioactive cobalt in 1948. So that's quite a long time ago. The current plaques that we use, the I-125 plaque, is probably by far the most common radioactive material that we use. That was first reported in 1970. And we're going to talk about this trial that really led to us feeling very comfortable that this is a very good option to treat patients with choroidal melanomas. And palladium-103 is just another type of radioactive plaque. Not much evidence that between palladium and iodine there's any difference as far as using those radioactive sources. They both can deliver very, very high doses of radiation to the eye tumor. The COMS, or its Collaborative Ocular Melanoma Study trial, was a very, very large trial that was done in the late 80s through the mid-90s throughout the US and Canada. There were 43 centers in the US and Canada. It was actually a very, very large trial because there was actually three trials within that. There was a trial for very small lesions where they just followed it. There was a trial for medium-sized tumors where patients, and that's what we're going to talk about, where patients, by the computer flipping a coin, or maybe it wasn't a computer then, but somebody flipped a coin, and patients either had the eye removed or they got eye plaque brachytherapy. And then for large lesions, there was a study that all the patients had the eye removed, but half the patients received a short course of radiation along with the eye removal. The biggest and probably the most powerful one was the medium-sized melanomas, which was the one that looked at removing the eye versus doing the eye plaque treatment. So for that study, the medium-sized tumors, there were 1,300 patients, again, in the US and Canada. I was a resident when this was going on and treated some patients at the University of Iowa, which is a big participant along with here. So pretty even, almost exactly half of the patients had the eye removed and the other half had the brachytherapy. Most of the patients received the treatment. You know, some patients, when they go on a trial, their eyes, they're in control of their destiny, and they may just change their mind. They don't want to be on the trial, and they might have they decided they really did want surgery or they really did want the eye plaque radiation, and they would be taken off the trial and receive the treatment that they wanted. But so over 90% stayed on the trial and got the treatment that they were assigned. One of the things was Erica was saying it's a diagnosis. You don't have to biopsy the tumor. In the patients that had their eye removed, 0.3% of those had something other than a melanoma. So 99.7% of the time, the ultrasounds and the pictures were accurate in telling it was a melanoma. The other 0.3% was some other tumor, most likely. I can't remember the details, but almost certainly that's what it was. And the survival was the same. Now, this is overall survival, so I don't want to scare you down. 20% of patients didn't die of melanoma at 5 years, but of all the population, 81% or 82% of everybody that was treated was still alive. You know, people die of heart disease, they get hit by a car or whatever. So not every, you know, but overall, the number of patients surviving at the end of the 5 years was equivalent. And 85% of the patients that had the eye plaque brachytherapy maintained their eye. You know, if the cancer come back, if the tumor came back in the eye, typically you'd have to remove the eye at that time. And in a smaller percentage, the radiation can damage the eye in some cases where you actually have to remove the eye because of complications of radiation, but that's uncommon. So, I forgot, what time did we start? Okay. So we're going to, as far as, we kind of said this, patients that had medium-sized lesions are the ones that typically we would treat with plaques. We do treat some larger lesions, some patients that fall into the category of having a large melanoma. We weigh the risks and benefits of doing the eye plaque brachytherapy. The chance that treatment might not work is higher. The chance that their vision will be worse is higher, but it still is a reasonable alternative in some selected cases as long as patients understand that it won't be that 90 to 95% cure that it would be for a medium-sized tumor. We use the I-125 plaque. Radioactive iodine 125 is the, if anybody's, it's the same, one of the common radioactive seeds we use in prostate seed implant as well. They're both, I-125 radioactivity has a low energy, so it doesn't travel very far, but it can give a very focal high dose. The reason we use eye plaque brachytherapy and don't just do external radiation like we do for a lot of tumors is that melanoma itself requires a high dose to kill. It's a little more resistant than some of the more standard cancers. So we have to give a really high dose of radiation in order to kill the cells. And with brachytherapy, we can give a very, very high dose of radiation over a very, very limited area. Some of this other thing, I won't talk about, this is some of this, the large shoulder and the cell survival curve. If anybody's a biologist, they might know what that is, but it just means you have to give a higher dose to kill the cell. And then the high RBE, which I have here, that's just because it's a lower energy X-ray, that is being emitted by this compared to the treatment machines, it actually might kill more cells for various reasons. So it might work a little better than the X-ray machine radiation for the same rad or centigrade. Also, the low energy just makes it very easy. The gold plaques we use, and I'll show you a picture of some of the gold plaques. The gold itself is a dense metal, and the dose on the other side of the plaque, on the opposite side of the seeds, is almost zero because the low energy is shielded very well by this plaque. And for patients, they're in the room, they can have family members in there. Their spouse can stay the whole time if they want. They can sleep in the room because that energy is so low. There isn't a high risk to them. There's insignificant risk to them because there is not much radiation to the family members or to the hospital staff. So we come into the picture. So Erica's team, Dr. Sabula, Dr. Daviddorf, they do all the work. They measure it, they do the ultrasounds, they take the pictures. They provide us with the information exactly where the tumor, the size of the tumor, how height, width, length, how far it is from the optic nerve and the fovea. From that information, we're going to figure out how big of a plaque we need. I'm going to work, me as a radiation oncologist will work with our physics staff to figure out what size plaque are we going to use and how many radiation seeds are we going to put in that plaque and how strong to make the seeds in order to give the dose to that particular tumor. We use a little bit different plaques than the Combs study did. The study I mentioned earlier that randomized patients primarily in the 90s, pretty much they all used round plaques and they were designed a little bit differently. And there were standard shapes. Here at OSU, before my time, but Dr. Daviddorf, who is still here, and Dr. Nag, who was a radiation oncologist before me here, they developed a process where they would design specific plaques for an individual patient so that it irradiated less normal tissue. And we've been doing that now at this institution for probably since the mid-90s. It was while that trial was going on. If they were on the trial, they got the round plaque. If they weren't on the trial, they got the Nag plaque. So Dr. Nag got to name it after himself. But the Nag plaque. And what it does is it does result in less damage to tissue. And these are just some pictures of the plaques based on where the tumor is at. So like this, it has these little, what we call rabbit ears, looks like a rabbit ear. For a lesion that's really in the far back part of the eye, this allows the ophthalmologist to more easily get it in place and suture it to the eye. And so there's a little bit more control and a little easier to secure it in place. We can put notches in the plaque if we have to go up against the optic nerve or if we're trying to avoid the cornea, if it's a more anterior lesion. These are the real plaques that have the radiation seeds in it. These are the dummy plaques, which are used by the ophthalmologist in the OR. They want to get it in place, so they're going to use ultrasound and look at the eye. They're going to they use a marking pen on the eye and outline where the tumor is at. They'll try to get that plaque in place, but during that whole time, by having one of these plaques, they don't have to be handling the radioactive source. They can just get this in place, identify exactly where we want the plaque to be, then they can take the real plaque and put it in place and sew it in place. So this is just a diagram of, if this is the Combs plaque, it's a round plaque. If it was a narrow, long tumor, and we would use a plaque that was more shaped like this, you can see that we would end up giving less radiation to tissue that didn't need to get treated. And this is just a picture of some of the plaques. These are the gold plaques with the islets. As Erica said, that's what the ophthalmologist is going to use to sew to the surface, to the white scleral part of the eye, the tough part of the eye on the outside. But here are the gold seeds. Or not the gold seeds, the iodine seeds. And depending on the size of the plaque, the size of the tumor, we're going to determine how many seeds. And we actually order a specific activity from the company that provides the seeds. And our physicists super glue them in place. They'll put a little mark in there, super glue them, and then we send them off to get sterilized. So this is just a diagram to kind of give you an example of So the plaque, this is the plaque. This is just kind of some seeds on end, and it's sewn onto the surface of the eye. And here's the tumor. So they want this plaque to be kind of just outside the edges of the tumor, and it's going to be giving radiation to the tumor. And this is just an example here of this plaque. And this is this is an example of what we call isodose lines. That means each line shows you how much radiation has been delivered over the period of time. So it gets really, really high doses in here, and as it gets farther and farther away, it gets less and less radiation. So that we prescribe to the top of the tumor. So we want our full dose to get to the tumor. So a lot of the tumor gets even higher doses. Our residents are a little surprised at how high those doses are when we compare those to the doses we might give another tumor. But it's very, very high, but it's also very, very limited. Whoops, very, very limited to just this area. The really high dose is just related to this area. Now, if we tried to have it exactly right here and exactly right here, we would be at the risk that we might miss it. And we don't miss, so we have a little bit of margin on the outside. So our first goal is to cure the tumor, and we want to have that just on the margin. So we make it a little bit bigger on the side to cover the tumor well. Did I go backwards? No, this is forward. But I kind of said this already. So we designed the plaque, we picked the plaque. We have a menu. I think we probably have, I lose track now, we probably have about 150 plaques in our inventory, and it's all, one of our physicists put it into a program. We can just we can sort it by size, shape, everything, and take pictures of them. If we don't have one that fits that patient, we order it, and we get one made to that size, and we just add to our library by doing that. And we get the dummy plaques, which just allows the ophthalmologist to be able to again, as I said, identify where to put that plaque so they're not actually having to, even though the radiation dose is low, it still is radiation. And there's no sense to get exposed to radiation if you don't have to. So they can really do most of the work with the dummy plaque, and then once it's ready to be placed, put the real plaque in. And I mentioned Dr. Subel and Dr. Davidorf are the two specialists that do the eye plaque brachytherapy. We're in the room. The NRC and Ohio Department of Health rule is if there's radioactivity, you have to have a radiation oncologist available. So I'm there to make sure the seeds are there, and if they fall out, I have to figure out what to do about it. But they don't want me sewing on the eye. I don't do that. Usually it's under general anesthesia or local anesthesia. And we kind of talked about this already. It needs to be accurate. I used to be in the Navy. This is the Blue Angels. We have to be accurate on the eye to minimize the dose and make sure we cure the tumor. They have to be accurate so they don't run into each other. I thought I had a better picture. This is a picture of the eye plaque actually being placed with the sutures. It's kind of blurry, but you can kind of see it's a gold plaque. Here's the eye, the cornea. And it's just sutured, very thin sutures to the surface of the eye and sutured in place. And then it'll stay in place again for 96 hours, basically 4 days. Goes in one day, and then 4 days later, within an hour or two of each of that, comes out. The patient will be in a private room for that stay. It's okay to have visitors. Non-pregnant adults can visit. If occasionally we'll have teenagers, family members, and then we'll have our radiation safety officers sit down with the teenagers and give them pretty clear guidelines and kind of minimize their stay. Prefer not to have pregnant females or children, or young children in the room. Again, the radiation exposure is so low, it probably doesn't matter, but we're just extra cautious. Some programs across the country actually send patients home with instructions, and then they come back on the day of surgery. We've never been quite comfortable with that, both for just make sure that they're doing okay, make sure that they're not getting increased pressure in their eye, make sure that they don't forget to come back. So we've always kept them in the hospital for those 4 days. As Erica mentioned, the tumor does shrink very slowly. The first couple of times, it's very likely to be the same size. But as long as it stays the same size and then eventually gets smaller, it's good. And it can take a long time to get small. One of the things that the study did show us, the clinical trial, so that we talked about, the Combs trial, we worry if most people, if removing the eye would give them a better chance of cure and a lower chance of cancer spreading, most people would choose to have the eye removed. And that's one of the big things and some wouldn't, but many would. One of the important things of the trial was that whether you had the eye plaque brachytherapy or the surgery, the chance of the cancer spreading and ending up taking your life is no different. Even if it came back and it needed the eye removed, still overall your chance of surviving is the same whichever one you did. So that's why we've been really comfortable offering eye plaque brachytherapy. Now, you still do need regular close follow-up for that and make sure that nothing's going on. Tumor gets smaller in, this is just kind of a summary, tumor gets smaller in most of the patients. About 15% eventually overall will develop metastatic disease. There is a significant effect on vision with this, and it is related to the size, it's related to the location. If the lesion is close to the optic nerve or the fovea, the risk of vision loss is much higher. The risk of losing the eye because of damage from radiation, scleral necrosis is probably even less than that, but that's dead tissue on the sclera of the eye, the white part of the eye. But a damage enough to cause removal of the eye is, boy, I think I'd have to ask Dr. Sabula, but it's been a long time since we've had to do that. It's probably 1% or less. But loss of vision is pretty significant. Now, our definition of loss of vision is worse than 2200. Even if it's worse than 2200, if you have some vision in that eye, many people would like that, maintain the eye and have at least some vision in that eye. And many patients will have good vision in that eye. Right. So, second to last slide, so we're almost done. Choroidal melanomas have a high, can be cured by eye plaque brachytherapy in a high percentage of cases, 90% or better. Survival, as I mentioned, just in the trial, it's comparable to enucleation in retrospective and prospective trials. There's negligible radiation exposure to others, and the patients most often are able to maintain their eye and often have useful vision in the eye and very often have vision in the eye. And this is the Battleship Wisconsin coming in on the Elizabeth River. This is Norfolk over here. My first radiation oncology department after getting out of residency was in Portsmouth Naval Medical Center right here, and the radiation oncology patients had beachside parking. They would park in the parking lot that was right on the beach and then walk in the hospital. So. Yeah. Okay.